Happy World Menopause Day! Woo! Welcome. My name is Shirley Weir. I'm the founder of MenopauseChicks.com, and it's my pleasure to welcome you to On the DL Live with Dana Levenson and the Dr. Heather Hirsch. Woohoo! I'm going to quickly tell you a bit about why I'm here and a very, very quick story, and then we are going to get down to business. So I founded MenopauseChicks.com. It's an online platform and private community where women can access quality, verified, evidence-based health information so we can all learn to navigate perimenopause to menopause to postmenopause with more confidence and ease. I have also worked with Vichy, who is our presenting sponsor tonight, since 2018. And I am not a skincare expert, but what I can tell you is that Vichy's commitment to skin science for the last 6 decades has resulted in them introducing a line in their Neovadiol line for both perimenopause and postmenopause skin. And that's because we experience changes. Hyaluronic acid goes for a decline starting in our 30s, in our 40s. And then of course, when estrogen declines postmenopause, we notice changes. And we often notice, members will say to me, you know what, Shirley, like what I used to use doesn't work anymore. And that's because our skin is changing. So in your bag tonight, there's a gift from Vichy. I am so grateful for their commitment to women's health education. And there's also a magnet. This is how I love to start off every single event, is reminding everyone that I deserve to feel amazing and you deserve to feel amazing. Some might say this conversation is long overdue. I have been talking about menopause publicly for the last 12 years. Quickly, the conversation can often turn to symptoms and suffering and negativity. So I love that if we can start with I deserve to feel amazing, and you can go home and post this somewhere where you will see it every day, and maybe the people that you live with will see it every day, it will be an amazing reminder. So a very quick story. 4 years ago today, I was in New York City, and I was on the Today Show to talk about women's health research. And I walked out and onto the set, and as I stepped onto the set, the producer leaned in and she whispered in my ear and she said, "Oh, by the way, we don't say vagina on air." So I'm very happy to say that last week I was invited onto a TV show to talk about nothing but vulvas and vaginas. And that's progress, right? Mm-hmm. And we have so much to celebrate, and I also just wanted to share that with you because tonight we are going to talk about vaginas. So it is my pleasure to turn over the stage to Dana Levenson and our distinguished guest, Dr. Heather Hirsch.
Thanks, Shirley. Thank you. Hi, everybody. Thank you, Shirley. That was a beautiful introduction, one I wasn't prepared for. We are going to be talking a lot about vaginas, but we're going to be talking a lot about other things tonight. Shirley's very humble. She came in all the way from Vancouver, and if you don't know about Shirley's work, I urge you to check her out at MenopauseChicks.com. She's really changing the health space for women and women in midlife. It's really extraordinary. So, I want to say a huge thank you to everybody coming tonight. I know the last week and a half has been very hard for most of us, so I'm very grateful that you showed up and that you are here, so thank you. And thank you to our sponsors, Vichy Laboratoire, also for the beautiful swag bags, really beautiful stuff. I've been using the Vichy products around my eyes. I don't know if you can see a difference, but really lovely serum under the eye, so hopefully that works in my menopausal skin. And I also need to thank Spin Master Toys for this unbelievable, gorgeous event space tonight. It is beautiful, and the team here at Spin, they've been just extraordinary. So I'm filled with gratitude, particularly for Anton Robbie, who is the co-founder of Spin. We were having a conversation this past summer. I'll call it a what's next conversation. And I was manifesting this, and voila, this is what happened. So my heart is oozing with gratitude right now. So we are talking, yes, we are talking about World Menopause Day, and I don't know if you know this statistic or if you've heard this, but it blew me away. Here it goes. 1.3 billion women around the world will go into menopause over the next 3 years. I thought that was a lot of women. Here's another stat, also blew me away. Women will spend 1/3 of their life in their menopausal years. That's a long time. So despite this information, and despite all these incredible female voices talking about menopause, finally, there are still so many women suffering. There is inadequate care, there's inconsistent care, there's so much misinformation, and we need to make a change. So I thought this was a perfect conversation for On the DL. When I started this show, I wanted to have incredible interviews with extraordinary people, creating these amazing conversations around topics that people weren't talking about out loud, hence On the DL, on the down low. So if you've listened to the show before, I have spoken with Heather on the podcast. I know a lot of you in here tonight have been on the podcast as well. You know that I'm very vulnerable, and I share a lot of myself. So we'll see how this conversation goes tonight. There may be a lot of that. We'll see. I would like to talk a little bit about Heather before we start talking. This woman over here is unbelievable. One of the most extraordinary women I have ever met in my life, albeit we just met an hour ago. However, we have had an interview already, and we've had numerous FaceTime conversations over the last few months. I saw Heather for the first time on the Oprah Menopause special, and I don't even know the word, but it changed my life. I said, I need to meet her, I need her. And then I just was on her Instagram every day, several times a day, until we connected. So I'm going to let Heather tell you all about her, but let's welcome Heather, she's amazing.
Well, thank you for that.
Well, you are welcome, Miss
That is
Heather.
so nice. You know, I think it's so funny because I think that there's this perception of me that's always cheerful and always happy, because people always say, you're always so positive, you're always so excited. People meet me and they think I'm like gonna be really tall. And, you know, then there's days where like my kids are in the tub and one pooped his pants and the dog, you know, barfed on the carpet. And, you know, it's just, life is a mess and I don't really feel that incredible. So thank you for that wonderful introduction.
You are welcome. Why don't we share a little bit of your credentials just to humble you just a little bit more?
Sure. So where do I begin? So I won't spare you all, I won't tell you the whole long story, but when I went to college, I know I'm going really far back, but I wanted to take a class called Women's Studies 101, and I thought, I'm gonna learn about incredible women. This is so exciting. Anyways, little did I know I was really learning about feminist theory, and I absolutely loved it. So I always wanted to take care of women, and so I thought to do that, you had to go into OBGYN, so I did a year of OBGYN residency. But I hated being up in the middle of the night, and I hated surgery because I would much rather talk to people, so while they were asleep, I didn't feel like we were really jiving. So I transitioned to internal medicine, and then I did a fellowship at Cleveland Clinic in midlife women's healthcare. My mentor, Dr. Thacker, she only did menopause, and women would fly from all over the country, all over the globe actually, to go to Cleveland. And I don't know if you've ever been there, but it's not that exciting. And they would come to get help for midlife, perimenopause, menopause. Their doctors would say, you can't take hormone therapy, or I don't know what's wrong with you. And I just had this aha moment that this was really where women were there was just a void of medical care, of support, of knowledge, of even just someone who would listen.
And how many years ago was this?
2014.
And not much has changed.
No, the pandemic was important in creating a little bit of momentum because everyone was at home, everybody was scrolling on wherever, and that really helped to permeate the conversation a little bit more. But in terms of, are there more doctors since 2014? No. Is there still the same myths and misconceptions since 2014? Yes. So a lot has not changed.
But we're going to talk about a lot has changed. There has been some improvement. We do have some good news.
We have some good news.
When I watched you on Oprah, one of the things that stuck, what Oprah had said, I'll only talk about Oprah for a minute. Everyone knows I'm a little obsessed with her, but only for a minute. And that is, she said that all of us cannot escape this. We can't out-exercise it. We can't yoga our way out of it or meditate. We can't diet our way out of menopause. It is coming for every single one of us.
Mm-hmm. Absolutely.
And yet there's still so many deniers. It's like, it's not going to happen to me.
I know.
I'm 40 years old and I feel great, and I'm not going to go through menopause.
You
especially
said
not
that to
like
me
my
earlier
mother
today.
Did. Yeah. What? Say that again.
Well, you said it earlier today. I said, there's nothing that I won't sleep through the night for, and you were like, well.
Oh, yes, right. Heather had said to me, she didn't want to lose sleep over something. She said something to me last night. She said, well, I don't want to lose sleep over it. And I thought, well, I don't want to be the cause of you losing any sleep. And then she said, oh, there's really nothing that causes me to lose sleep. And I said, well, you have not gone into perimenopause yet then. That's obvious, right?
We're at the very beginning stages. I will tell you about my symptoms, but we're at the very beginning stages of early perimenopause.
So I think this is an interesting way to look at menopause because we talked about this as well, and it kind of hit me a bit because nobody talks about menopause as a life or death situation. And you say it is a life or death situation. Why is that?
So, what a loaded question. Mm-hmm. So for many reasons, I actually do think that while I'm potentially being a little drastic about it, mental health changes are so common through the transition, and so many different forms. Tends to start with irritability and then insomnia and anxiety, and then it can really transition sometimes into anhedonia and severe depression. And maybe that doesn't happen to everybody, but I have seen patients lose their life. I have seen women really become so crippled by either their symptoms or their mental health changes. We know that actually several of my good friends are urologists in the States. We talk all the time about how vaginal estrogen saves lives, and we're not kidding, because the three things that can lead to a healthy woman living in a nursing home is recurrent urinary tract infections, dementia, or fracturing a hip or spine. All things that can happen because of menopause. So it is life or death. It absolutely is. And the fact that women have these big hormonal shifts throughout their life, and particularly through perimenopause and menopause when we stop making these sex hormones anymore, but it affects every organ system in our body, has not been talked about, is crazy to me.
Right. It's crazy, and it's crazy making. And it makes women feel even crazier because we're already made to feel a little bit insane, albeit just being a woman. And then we go into this transition stage in our lives. We go to see our doctor or doctors, and we're told over and over again that, oh, what's your stress level like? What's it like at home? What's your work life like? And nobody is bringing up the conversation that maybe you're having such a dip in hormones that is actually making whatever's going on for you that much worse. So I find that staggering because I hear this over and over again. And it almost makes me angry because I think about what it was like going through puberty. All we talked about when we were younger was we're gonna get boobs and pubic hair, we're gonna get our period, and it's gonna hurt, and we're gonna have sexual feelings, and boys are gonna have sexual feelings, and there's all this build up to puberty, and then you get your period, and it's like, this is amazing, and it hurts like hell, and your boobs hurt, and you're thinking, well, this is so great, and you're in it, but you learn so much about it, and then you learn so much about pregnancy. And then you learn how not to get pregnant. And then you learn all about what happens when you do get pregnant. And we learn about babies, and we learn about giving birth and what that's all like. And then the conversation stops.
Yeah.
Stops. I don't remember ever learning about menopause. I don't remember a doctor setting me up and saying, well, by the way, now that you've gone through your baby making years, let me tell you what's next. I never had that conversation. I never had that conversation with girlfriends, sisters, mom. Nobody talked about menopause. So then this huge stigma existed when you start to go into menopause. Certainly for myself, I remember thinking, oh my God, like, had I known a little bit about it, perhaps my eyeballs that felt like there was sandpaper in my eyes every morning.
Yep.
I thought, something was happening to me. Someone could have said to me, oh, maybe that's perimenopause. Or how about this? I would look at a cookie and I would gain a pound. Nobody said if you look at a cookie, you're going to gain a pound. Or if you eat the cookie, you're going to gain 2 pounds.
I was going to say 10.
No, you said 10 pounds? 10 pounds for a cookie. That's not great. That's not good news. So why is it that nobody talks about that?
Certainly lots of things come to mind, but you're absolutely right. The way we think about women's health is absolutely shaped around our reproductive status. So it's either you want to get pregnant, you are pregnant, you are just done being pregnant, or you want to get pregnant and you can't. Notice all of those have to do with the status of your uterus and its activity. But we don't have enough information. We don't have enough doctors discussing what about women's health. Everyone wants to talk about women's health, and that's great, but usually in the realm of contraception and pregnancy or obstetrics. So what happens to women later on, typically in our late 30s, 40s, 50s, and then beyond, has been ignored for so long. In fact, I have a great friend in the UK, and the UK has been doing a really great job with a lot of advocacy, and especially with policy and political change. And over there, they have incorporated menopause education into schools. Like imagine, I kid you not, imagine going to, what's that class in 9th grade? Sexual health puberty class. Did they teach? They don't teach about menopause.
I didn't go to any sexual health class. I would have loved that.
Of course, so she said to me, well, what do your schools teach kids about menopause? And I said, nothing. She said, well, what do they think about, the grandmother at the bus station? And I said, I don't think they think anything. She said, wow, that is crazy. And so the discussion really has to start a lot earlier. But you're absolutely right in that the medical system, the medical training is taught to think about women's health in terms of what our uterus is doing. And if it's not doing anything, then it kind of like, well, that takes care of that. But that couldn't be farther from the truth. It couldn't be farther from the truth. So that's why having so much awareness around menopause, having it be on TV, having public figures talk about it, we're changing that. And I say all the time when anyone asks me, what do you think is the reason for the change? I say every single time, it's not coming from the medical community. Yes, there are certainly a handful of doctors talking about it, but you've got women who are galvanizing and activated, which is then in turn slowly waking up the medical community. Truth be told, if I had never done that fellowship training, I don't know that I would know anything different.
That's interesting. So we talk about classic symptoms of menopause. So I just talked about stigma and stereotype. A lot of women don't want to say that they're in their menopausal years because they're afraid of being stigmatized as dried up, itchy, sweaty, you know, all the things that we don't want people to think we are. I mean, we are, but we're so much more than that. And there's 34 symptoms, you said? And I think you said that to me, and I thought 34. Well, I just thought of the day that I just had, and I can tell you there's like 34 times 10. And I know I can't blame everything on menopause, but every time I have this new symptom, and I think, oh, I have to figure out what that is, and then I take a step back, I say,
I wonder.
yeah.
This is exactly why when you were talking about how you go to the doctor and you say, I'm feeling this and I'm feeling this, and they're just like, I don't know. It's really because, again, this hormonal change has never been incorporated into medical training, has never really been thought of as an etiology or reason for these symptoms. And even though we now know more about vasomotor symptoms and hot flashes and insomnia and vaginal dryness, not that we know everything, we're still learning, when it comes to like the uncommon symptoms like itchy ears, burning mouth and gums, the zapping sensation.
The what sensation?
Zapping sensation. Who has zapping sensation? Anyone in the room feeling like bugs are crawling all over you?
Okay, see? I said I knew there was something.
There's so many symptoms, and if we're still learning about hot flashes and night sweats, it's really hard in the States to get the NIH to write you a grant for bugs crawling on me symptomatology. But I hear this all the time, and there's so much that we don't know. But being that I've had the pleasure, like truly the pleasure of having patients over the last decade, that has given me this clinical backbone, this clinical knowledge of all these symptoms that, then I start to hear a lot. So bugs, feeling like bugs are crawling on your skin, it's right up there with the commonly known but more uncommonly discussed symptoms.
I want to talk about symptoms. I really want to talk about symptoms. I want to talk about hot flashes and the warning signs of hot flashes. But before I do, I want to give you a scenario. I want to throw many scenarios to you tonight because this will set up the idea of going to speak to your doctor about symptoms. So here's a scenario. There's a woman who, let's say she's 38 years old. She goes to the doctor and she says, I would like the birth control pill. And the doctor replies, okay, are you sexually active? Yes, I am. Do you smoke? Sometimes. Well, what's sometimes? Well, I don't know, occasionally, socially, on the weekends, when I drink. Okay, well, you shouldn't do that. You shouldn't smoke when you're on the pill. But she gets a prescription for the pill. Same doctor, same day, woman comes in, she's 42. She's a list of symptoms, a list of how she's feeling. How old are you? You're 42. How long has this been going on for? A few months. Okay, well, maybe I should start some estrogen, maybe HRT, something. No, you're far too young. And she goes home with nothing. They're a few years apart. The 38-year-old gets the pill, and the 42-year-old gets nothing. So what can a woman do? She goes to see her doctor, whether she's 38, 32, 45, I don't care, 55. What can she say to her doctor to help the medical intervention begin?
So such a good question. Essentially, what we have here is someone who is still having cycles, not yet menopausal, because the menopause by the textbook is 1 year of no periods. But as we discussed yesterday on the social, there's a lot of research to show that women experience very similar symptoms in perimenopause as they do menopause. It's just that they're still cycling. And so this ability to hone in on this being hormonal for clinicians, I think, is sometimes hard. And interestingly, I also get a lot of comments from women saying their doctor will not prescribe HRT or postmenopausal doses of estrogen and progesterone when they're still having periods. And so that's really, really difficult. I hear that all the time.
I hear it too. So
what gives?
Yeah.
I don't know. Truthfully, I really don't know because...
Do you demand it? Do you go see another doctor? What do you do?
I think what's really helpful And it takes a little bit of work, but I always recommend go to your doctor, and if you can, try to make a separate visit. Don't do it at your annual exam because they're trying to do so many things.
Right.
Try to make a separate visit, and if you can, bring something that you've been tracking. So here your periods are, right before your period, you get hot flashes, insomnia, irritability, every single time, 4 months in a row. And then say, really almost have to use words that might sound familiar. I think this could be perimenopause. Do you think potentially there's some options here? It depends how proactive you are. I like to prescribe either an estrogen patch for my patients or sometimes progesterone for my patients. It really depends on symptoms. But even if you say, this week is really difficult, what about the option of a progesterone patch? They might say, oh, well, I don't know. They'll say, well, what about birth control pills? And they'll say, oh, well, okay. And you can say, I could get pregnant. Okay, well, I'll give you birth control pills. Well, if you would give me birth control pills, why wouldn't you give me postmenopausal hormone therapy? And they may kind of come up with like a blank stare. But the reason that I advocate, or the reason that I encourage women to go this far and take your doctor maybe down this road is that ultimately that's going to cue your doctor in. The more they start to hear this, whether it's your nurse practitioner or it's a PA or whomever, that they need more training because everyone's coming in asking about the patch before their period. And eventually they're gonna have to start to realize they've got to really up their skills on this area, because while heart disease is important and lung disease is important and rashes are important, so is perimenopause and menopause, because everyone will go through it. So they've got to learn.
So you're saying make a list of symptoms and track it, so
Track it.
you are armed with information when your
Yes.
doctor starts throwing
Yeah.
things at you.
If you want to get even more savvy, say, I tried this over the counter, I did this, I think it's perimenopause, I'm following these doctors. If you want to even say, what have you tried? What do you think it could be? This is something I do for my patients. I always ask them, do you have a guess as to what you need? And it's interesting because 7 years ago, everyone was like, I don't know. Nowadays, my patients are like, well, I think I need the patch and progesterone. I'm like, great, okay. The reason I like to ask that question is I like to meet my patients where they are. And again, because there has been a little bit of a shift in the last couple of years, they will sometimes already have a clue. And certainly women who see me may have already been watching some of my things, so they may already know. But essentially what you're doing is reverse engineering that for a doctor who may not feel as comfortable. You're kind of saying, I think I need this. Now, of course, there's different health systems, there's different healthcare options in, of course, the states and et cetera, but you can always keep searching for another provider, a second opinion. I'm probably sure Shirley's got a lot of resources as well as to where to go to find a knowledgeable provider, because that is so much of the battle, and one of the things that I think about every single day as I'm working on new innovations to really help women.
It's different in Canada than the States. I have to tell you, it is different. We are having a crisis here, a family physician crisis. Not everybody has primary care in this country, which is very unfortunate. And even the ones that do, it takes a while to get in to see your primary care physician. And sometimes you get in and you only are allowed one complaint, and that's it. And you can only talk about that one thing. And then, well, you got to make an appointment. You got to come back a couple weeks later. And then you get on a list to see a specialist, and you can't get in to see a specialist for a year. Many clinics in the city, there are wait lists for at least a year. So you really want to really make sure you get what you need from that 5-minute consult from your doctor, or if you're lucky 10, and figure out what it is that's going on for you at that moment.
Yeah.
You gave this unbelievable scenario to me about what would the world look like if every single woman in the world knew she was going to be diagnosed with hypothyroidism at 40. I thought that was mind-boggling. And that there's an actual pill. And you said, and there's an actual pill that will help her sleep. She won't gain weight. She won't be sluggish. Her libido won't drop. She'll have energy. I was like, bring it.
Yeah.
She said, there is such a thing for women.
Yes. You know, it's funny because...
And what's it called, Heather? Why don't we tell everyone what's it called? We're going to say it out loud, HRT. Let's say it.
Oh, yes.
Say it loud.
Hormone replacement therapy,
Yes,
right?
it is. And it's gotten a lot of bad press over the last several years. I have women in my life who I'm very close to who still say, I'm not taking that.
Yeah.
I will not take it. I don't even want a little.
Yeah.
And they're sweating as they're talking to me.
Yeah.
And I think, wow, those beads of sweat on your lip, does that feel nice? And I actually said to a friend of mine the other day, as she was saying to me, no, I don't want anything. And she's going like this, I don't want anything. I'm like, okay, how often is this happening? Not that much, not that much. I'm like, how often? Like a couple times a week? Oh no, more than that. I'm like, a couple times a day? It depends on the day. I'm like, okay. But she's not alone because her physician has also probably made her feel post 55, post 52, whatever it is, you don't need it. But a little bit can go a long way. Now, I'm not going to push HRT on anybody in here. I'm just going to advocate for what I know and how much it changed my life. And I struggled terribly, and I struggled in silence, and I had to make huge life changes that people thought I was bananas. They're like, what are you doing? I made a career change. I made several life changes personally, and I had to do it because I couldn't function. I couldn't do what I needed to do and feel like I could be alive. And that intervention, that medical intervention changed my life. And I'm asked all the time, well, why do you feel so good? And how do you stay in shape? And of course it's consistency and I eat well, but it's HRT. Mm-hmm. So I'm not telling you to run out and get HRT because it's not for everybody, right. But it worked for me. So right. That's why I like to spread it and share my experience. But maybe you can talk about there are people that can't take HRT and shouldn't take HRT, and there are alternatives.
Yeah. Well, I'm sorry that happened to you.
Well, it's going to happen to most people, right? So they're women.
I mean, it's incredible that you've taken that experience and now been able to share that experience. Mm. And I get to see this all the time. You know, I want to touch on who's not a candidate for HRT and what your options are. But if we sit on that for a second, I think the statistics are fascinating. First of all, if men lost their testosterone and their balls shriveled up at 45, do you think that they would take testosterone?
Take it. They'd be giving it out on the streets.
I know.
It'll be like Trident gum. Here you go.
They do. Essentially, I'm going to use some really harsh words, but we basically get naturally castrated at like whatever in midlife. And for some of my patients, it's earlier. I have a 23-year-old. I freaking love her. She lives with her roommates, and they're all on birth control, and she's on her HRT. And so at night, they all take their different formulations, and she's like, I'm over here with my vaginal estrogen, and my girlfriends are all taking their birth control. But vaginal estrogen. Yeah, we'll touch on that. So at the peak of hormone therapy use in the States, about 60% of women were on HRT in the 80s and 90s. And in 1992, the American College of Physicians strongly advocated for the use of hormone replacement therapy. Now, in full transparency, I'm 41, so at that time, I was a baby. But the physicians who are a few decades older than me, they always come up to me after I would teach, and they're like, I never took my wife off HRT. Right. And I was like, really? And everybody remembers that study. So 60% of women were on HRT in the 80s and 90s. And then after that study came out, it dropped to 5% or less. Mm. At the same time, prescriptions for antidepressants skyrocketed, and women have really been suffering since. And so if you think about that, all the advocacy that we do, now the statistics show in the States about, I'm going to even be positive about this one, let's say 7 to 10% of women are on HRT. Oh my gosh, I would be happy if that number doubled, if we got like 20% of women on HRT, because probably 85 or 90% of women are candidates for HRT.
So what happened with this study? Because from my understanding, it was one study out of the UK, correct?
United States.
Oh, it was the United States.
There's a couple.
There was one, I thought, from the UK that cited breast cancer.
There's a couple.
And the British press went bananas over it, and then it spread like wildfire.
Yes.
And from that, it became, as you said, I feel probably women 10 or 15 years older than I am are the ones that suffered the most, because they were like, no, sorry, you can't have it. And in fact, I met a woman the other day in the dog park. She's 63, and she just had mentioned she wasn't feeling great. It's like, oh, I hope you feel better. She said, no, it's just, my doctor took me off my HRT, and I feel like hell. And I said, why?
Of course.
Why did you do that? Are you okay?
Yeah.
And she said, well, I've been on it for 10 years. I said,
Yeah.
what does that mean? She said, oh, no, you can't be on it for more than 10 years. I'm like, I didn't know that.
Myth.
Okay, so she said, you can't, and I thought, well, what are you going to do about it? She said, well, I have to just sort of ride it out right now, because I can't get it from him. He won't give it to me. I'm not sleeping. I'm hot flashing all night, and I'm in the worst mood.
I know.
And I felt terrible for her. I felt really bad for her. So I thought, wow, so I only got like a few more years left on this? That's too bad, because I feel great.
You know, there's so many myths that came out of the study. The length of use is a huge one, and let's knock that one right out of the
So
park.
that is a myth. You can stay on it for
Stay on it
decades?
forever. I tell my patients you can stay on it to your last day on the planet, or if you also want to come off, I'm also not going to, say you must take it forever. I always tell my patients it really depends on your health goals, on your priorities, on the rest of your health, but there is no longer any stopping point. So you can take it as long as you like. And that study, the one that really scared physicians about the use of hormone therapy, that's when all those women were pulled off. So it went from 60% on HRT to 5% on HRT. And that deep bias that estrogen is dangerous and harmful is why we're still sitting here today. It's why we're still sitting here today.
So
it's why we're still sitting here today.
who can't take it?
So by the textbook, and I will use the textbook for today, anyone with a history or active breast cancer, anyone with end-stage liver disease, anyone with a history of a stroke, anyone with a history of an unprovoked blood clot, that means a blood clot that you get just from, you're just watching TV, versus say if you have a car accident, a blood clot after a car accident, that's traumatic. So that had nothing to do with estrogen. Or unexplained vaginal bleeding. Those are the reasons that we pause, although I will say no more, but if I had patients with any of those past medical history come to see me, yes.
Okay. What would be the alternatives to that if someone still feels, perhaps they feel, I've gone through it.
Yeah.
I'm in my post-menopause years, and I got through it, and I didn't take anything, and I still don't want to take anything,
Yeah.
but I'm uncomfortable. I
Yeah.
do have some symptoms. What are some of the things that people can do naturally?
Well, vaginal estrogen,
Is that natural?
to me.
Yeah.
Vaginal
Me too.
estrogen. Do you like how I snuck that in there?
Yeah.
So vaginal estrogen, any woman on the planet is a candidate for vaginal estrogen. There is no contraindications because it does not travel systemically. And truth be told, while hot flashes tend to go away after some time, sometimes they don't, but vaginal dryness, genitourinary syndrome of menopause, is progressive. It will never get better with time. So anyone can take vaginal estrogen. No,
Wait, what did you say? It never gets better with time?
it never gets better with time. It never gets better with time.
Okay.
Estrogen is not coming back. So the tissue in this new pH, because of the loss of estrogen, it is a progressive syndrome of vaginal dryness. Although the term vaginal dryness, I actually think makes it sound cute and sweet. Oh, a little bit of vaginal dryness? No. Remember I said that menopause is life or death? As a resident in internal medicine, I saw many women pass away because of urosepsis. That is a urinary tract infection that gets into your bloodstream. And had she been given vaginal estrogen decades before, that would have prevented it.
So here's another statistic I want to throw at you. 500,000 doctor visits are dedicated, in Canada, are dedicated to UTIs.
I know.
Now, I must confess, I must have been probably 100,000 of them must have been me alone going to the doctor every month. I have another UTI. I have another UTI. And I kept saying, well, what's wrong with me? Why do I keep getting these UTIs? It's your body. And then the antibiotics, and then all of that would come along with it. It was just impossible. But all that has stopped, so I can tell you that's all gone away now.
So this is such an important question because it sounds so nefarious. It sounds like, oh, just urinary tract infections.
Oh no, and the pain.
Oh, and the pain. And in the States, what we do is, because we're also so busy, we just send antibiotics right through we don't even worry about getting your culture. We just send you antibiotics, but that could lead to antibiotic resistance over time. So the fact that we're not thinking about menopause is literally killing women. It literally is. Now, let's talk about non-hormonal options because you asked. There's a new medication, and this is pharmaceuticals, but we can also move into lifestyle. But there is a novel, new non-hormonal medication for hot flashes. It actually works by decreasing your core body temperature, kind of turning down the dial in your hypothalamus, and that medication is called Veoza. And there's a wonderful non-hormonal medication for low libido. So let's hear it for that. Because women have two medications.
It's the Veoza works?
No, it's different. There's a medication called flubanserine, which is a non-hormonal medication for low libido. Considering that there's 2 FDA-approved medications for low libido in women, and I think like 50 for men's sexual health, that's something to celebrate.
Is that in Canada?
I don't know. I don't know.
I haven't heard of it.
It's called flubanserine. It's FDA approved for hypoactive sexual desire disorder.
Wow.
Lifestyle is really important. I'm, never going to minimize lifestyle because things like sleep, your mental health, your diet, if you're moving your body, of course, they are the fundamentals of how you treat your body. But just as Oprah said, just as you said, menopause is still a physiologic change, and so sometimes the symptoms are so severe you cannot out-yoga your symptoms.
I did try, and I will tell you, I was working with a health practitioner for a few years, and I thought, I'm on the right track, and it was all about diet and lifestyle and exercise, and I just wasn't feeling great, and there were so many things happening to my body, and I found myself complaining all the time. It was either complaining to myself, complaining to her, and this is a woman, and she told me, I still can't believe she said this to me. She said, "You need to suck it up, Buttercup." That's what she said to me. I was like, bye-bye. I need to find someone else. Suck it up, Buttercup. I thought, isn't that what we said to our kids when they weren't behaving? I was so angry. I said, I can't suck it up. I can't spend the rest of my life feeling this way. There's just no way, because this is just unacceptable. I can't.
There's a myth.
Diet and exercise only can go so far.
Only can go so far. There is this myth, and actually I have a great friend who's a fitness instructor, and there is a really persistent myth that if you're healthy and you take care of yourself and you do self-care and great sleep hygiene, that you're just going to fly through menopause. And you're a perfect example of that. I'm going to take a guess that you take care of yourself, or you try to, right?
I do. I work very hard. I'm not going to lie.
Exactly.
I do, yes.
And I think this message, just keep working harder, just work on that sleep hygiene, just journal a little bit more. That's not going to change your hormonal status.
Right. Yes, I'm journaling, and I'm grateful. I have my gratitude
got the candles
journal.
burning.
Exactly.
I've got the incense.
I've got my matcha tea in the morning. I've got it all going, but you know what? I'm looking at the cookie, and I'm gaining a pound every day that I look at a cookie.
I know, and it's so frustrating. And so again, that's why we're here, is because the fact that we have this huge physiological shift that's been completely ignored for up until now. That's why we're here. We really need to start breaking down these barriers. They've done a good job. Oprah did just do a new Live the Life You Want series on obesity.
I saw.
And what's fantastic here is the message is this is a hormonal disruption. This isn't your fault. You know, and this is so true about metabolism. And the same thing, it's very parallel to menopause. These things are not our fault. We're not exercising wrong. We're not eating at the wrong time.
Oh God. If I hear timed nutrition, one more time from a healthcare professional, timed nutrition. Pull my eyelashes out. I'm like, honestly, it's not working. It didn't work.
Yeah.
So, I mean, you hear it all. You talk about this in Unlock Your Menopause Type. You break it down for women to figure out what their type of menopause is before they actually go at the symptoms.
Yes. You know, thanks for bringing up my book. I love my book. It was like a labor of love.
Love her book. There you go.
I am telling you, 10,000 TikTok posts would be so much easier than writing a book.
Oh no, I can't believe you just said that. I feel like crying. I love your book.
Thank you.
I do.
It's a true labor of love. And for all my perimenopausal girlies, there may be something else in the pipelines. Because this book really does focus a lot on menopause. But because I saw so many different types of menopause, I'll throw out one example. Like, we're talking about exercise. Now, again, you cannot do it wrong. You can't, like, move wrong. But if you have full throttle menopause, like hot flashes and night sweats and dripping wet and just exhausted and irritable and losing your hair, like, a HIIT workout's not gonna be great for you. You're just gonna be sweating and exhausted, and you won't even get through it, and then you're just gonna stop. For the mind-altering menopause type, which we opened talking about mental health, in the United States, the age bracket of women with the highest rates of suicide is Caucasian women aged 45 to 55. So mental health is extremely important. And there's some great research that swimming and like low intensity aerobic exercise and then graded exercise is so good for our mood. And so those are just kind of some examples where, you know, I try to, in my book, cheerlead you on by helping you kind of individualize it. And I can't individualize it for millions of women in a book, but knowing kind of what is the main symptom driver for you or how old you are when menopause started, because again, I have a 23-year-old and I know I will have more 20-year-olds, can really help you better get through it. That was my hope for my
Can we
book.
play the symptom game? Because
Yes.
I know you love the symptom game.
Oh, I
Whenever
love that.
someone throws a symptom at you, you're like, oh, well, you should take this and do that and that. So I want to play the symptom
Okay,
game.
am I
have
okay.
the symptoms somewhere,
Okay,
but I
she
don't
is
even need to
not-
look because I'll just throw them at you. Okay, hair loss.
Oh, gosh. Okay, well, so, oh my God, how detailed do you want me to get?
You could throw it out there, whatever. I'm sure there's women here that, you know,
okay,
I
hair
will tell
loss.
you, I'm wearing hair extensions. I lost tons of hair. I lost tons of hair.
Oh
But
my
my hair
goodness.
has been coming back, which is really nice.
So estrogen might be the answer for a lot of these things, but by no means is this the individual answer, but estrogen is so good for hair. In fact, oral estrogen is a little bit better than transdermal. Other good things for your hair is going to be minoxidil or Rogaine. Now, Rogaine, of course, you know, it's the foam, you put it in your hair, but you can also actually take it orally, and then you just don't have to frickin' do it every single day. That is a prescription, so minoxidil. There's a ton of dermatology, you know, there's all sorts of fancy things in dermatology, but avoiding that, you know, a lot of my patients really like Nutrafol, which is a pretty costly vitamin. They're probably scoring big, but what you want to do is make sure you've got good biotin, zinc, folic acid, iron.
I want to ask you about biotin. So I was told that all the thousands of dollars I spent on laser hair removal, all my hair was going to come back on my legs and everywhere else if I took biotin. Is that a myth?
Nothing's ringing in my head, so I think so.
Okay, it's good to know. Interesting.
Yeah.
Okay, so this is a huge one, of course, low libido.
So I'm going to go with testosterone on this one. Testosterone. And now, libido is made up of many things. Libido is made up of, are you tired? Do you feel well? Is your partner home?
Is your
a
what?
dog in your bed?
Did you say is your partner home?
Is your partner home?
Well, that would help.
But it's truthfully, my patients will tell me this all the time. And I'm like, well, how often are you together? And they're like, well, he's a pilot, or he's traveling, or I'm traveling, or the kids are home, or I'm going to colleges, or I'm going to games. It's like, you don't even see each other, of course. So it's made up of a lot of different things.
Okay, let's say your partner's home.
Partner's home.
Let's say he's right there beside you, and he's looking cute as ever, and you haven't had sex in weeks.
Okay.
Not because of him, but because you just don't feel like it.
You just don't feel like it. There's, again, first of all, I said testosterone right off the bat because I do think it's probably the most effective, but without actually digging a little bit deeper, there could be a lot of things that are going on there. So, and honestly, pain is such a huge reason women don't want to have sex. And when I ask that, I'm like, well, is it painful? And they're like, well, yeah. And I'm like, well, of course you have no libido. It hurts you.
That's vaginal health.
So that's vaginal health and pelvic floor health. So if it's uncomfortable, if it's anything other than extraordinarily pleasurable, why are you going to want to do it? Now, big drivers of sex, of course, when we're younger is to reproduce. And a lot of my patients either have a gold star already or, they've kind of said their bodies kind of said, we're not going to reproduce anymore. And so there is some natural changes in libido that happen. And society tells us we should be sexual all the time. We should be spontaneously sexual every single day. And that imagery is very dangerous to us because no one sexes like that. A doctor once told me, so I'm going to take it from her, this did not come from my own brain, but she said, when was sex ever spontaneous? Even when you were 20 and you were going on a date, you put your sexy underwear on, you knew. It was never spontaneous. That's
it's
kind
never
of a
like
myth.
it is. I know, we watch it on television shows, and the first thing I think is, was she ready? Ugh, how could she do that? She wasn't even ready. Did her leg shave? Did she shower? Did she know?
Yeah, right, exactly.
And she's in her 50s? This is
Come
so
on.
not reasonable for me.
Right, this
no
imagery
way.
is really harmful to the woman who's sitting in bed, laying next to her partner and going gosh, there's nothing wrong with you. There is nothing wrong with you.
But a little testosterone can make you feel better.
Little testosterone, so you gotta make sure there's no pain, but women also need to make sure they feel well. So interestingly, they put women in MRI scans who don't have low libido, I don't know, right? And they scan their brain and they see no sign of activity in their prefrontal cortex. So you can't be doing the list, you can't be worried about your son, you can't be worried about the vet, you can't be worried, you got to really, when we're enjoying sex, there is nothing going on upstairs. So you all laugh because you're like, when's the last time that's happened? I don't know either. So, anyways, while I kind of said the first thing I said was testosterone, there's so much more that goes into this. So, a lot of really great sex therapists talk about scheduling it, and that sounds so unsexy. Like, hey, sweetie, how's the 24th? But when you take out that idea that sex is never really spontaneous, and it's kind of and it doesn't hurt, and you're sleeping well, that I always say to my patients, go on a date, do all your worrying in the morning, get your list done, then go to dinner and turn off your prefrontal cortex and see if it's enjoyable. Because sex...
Okay, say all of that isn't working. What do you take?
Well, so then a little bit of testosterone is a really great option because it really can activate the parts of your brain that are rewarding you for sex. And there's also some other options that are non-hormonal. So I mentioned the medication Addie or flibanserin. Some of these dopamine agonists, again, dopamine is like your reward, it's like the reward neurotransmitter. So there's some medications that can increase dopamine in your brain that increase reward for certain behaviors. Also, free pro tip, read erotica. Telling you.
Read erotica.
Yeah.
Okay, read erotica. Testosterone and a little erotica. Sounds like a good recipe to me.
I am telling you. The reason I say read it, people can watch it. I'm probably projecting. I think as women, if we can control the imagery, it feels a little bit better. Because if you're reading it, you can make the imagery whatever you want. But you've got to return that circuit on, right? So lots of times for women, in, especially research shows that, wow, we're really talking about libido for a while. In our 40s, libido just like for everyone, because most of the time there's so much stuff, it just doesn't make it on the list. And you literally forget to turn those circuitries on. So by reading erotica, it can remind you how to activate those circuitries.
Okay, next symptom, weight gain.
Oh, weight gain. So weight gain, here's what I actually think. When you think about weight gain, don't think about what you're eating or how much you're exercising. I want you to think about how much you're sleeping. Because I think that disrupted sleep is a huge component to the downstream effects that lead to weight gain. Now, women who take hormone therapy actually have less diabetes. So that means that estrogen is talking to insulin, the other hormone that's playing a role in what we're doing with sugars and carbohydrates and et cetera. So our hormones play a big role. Our sleep plays a really big role. And everyone forgets about sleep. I see a lot of women actually over-exercising and under-eating. I see a lot of that, but we're so afraid, women are so afraid that if they either stop the exercising or they eat a little bit more, they're gonna gain weight. So I actually see a lot of, and it's almost like 90s diet culture comes back, because we're just like, that's what we remember. There's a lot of course, new medications. So there's semaglutides. We've all heard of like Ozempic and Wegovy. Those actually are great medications. We can talk about that at another date, but they really can help because, again, I think of obesity, which is a little bit different than I just gained 10 pounds, but trust me, I know what it feels like to gain 5 or 10 pounds and not recognize yourself. So it's not that you have to gain 50 pounds, but there is a lot of certain medications.
No, and usually it is the perimenopause to menopause where it is just that very subtle, it's even 3 pounds or 5 pounds, and you feel
just like a different human.
Yeah, you feel wretched because you're like, you're trying to do up your pants and you're so swollen.
Yeah.
And then you're told basically, well, it's your cortisol levels and you're stressed, and no one really talks about the idea that there's an estrogen plunge, right? It's more about, oh, it's the stress and it's cortisol. Well, like you said, all the hormones are speaking to each other.
Gaining 5 pounds is really hard because you go to your doctor and you're like, I've gained 5 pounds, and they're like, I've got other things to worry about, sweetie, but it really can affect you. Anything can affect you.
So we talk about World Menopause Day, and this year the theme is cardiovascular health.
Yeah.
And we've been talking about hot flashes, but hot flashes, I mean, it's more than a nuisance. It is much more than a nuisance, and it's a warning sign. And this is where there's that disconnect around taking it quite seriously, how many, how often, how it's impacting your health. And so maybe you can talk about how important cardiovascular health is.
When I used to teach this to the residents, I used to try to, how would I make menopause fun? And when I was at Harvard, everyone wants to be a cardiologist. So I would show them all the slides about how estrogen decreased the risk of cardiovascular disease. And they were all like, what? How long have you known this for? And where I was like, literally forever. And it really wakes them up because when we talk about menopause, the American Heart Association in 2020 stated that menopause needs to be considered an independent risk factor for heart disease. Yeah.
Wow.
And again, studies showed, even the study that scared most women or scared most doctors, that if you started within 10 years of menopause, women had reductions in cardiovascular disease, reduction in all-cause mortality, they lived longer, and had less heart attacks. And my cardiologist's eyes, their budding cardiologists are like, wow, has anyone done research on this? I'm like, please be the first, be among the new generation.
So if there are women here who are hot flashing, what do you say to them?
Well, what a hot flash really is your vessels squeezing and then releasing. Think about that for a second. Does that sound like at all healthy? No.
Not really.
And so there's research that shows that women with more persistent vasomotor symptoms do tend to have earlier cardiovascular events. Again, the fact that then we're not talking about what is the treatment, which would be estrogen, it's crazy. It is crazy. Estrogen, interestingly, when you start it within 10 years of menopause, is an anti-inflammatory. It releases nitric oxide, which opens up your blood vessels. So it vasodilates your blood vessels. And so that's why we have less heart disease. It opens up all those vessels around the heart, and you get this beautiful blood flow around your heart. And persistent hot flashes have also been shown to be linked to increased risk for cardiovascular disease. So both severity and length or years of symptoms can increase the risk for cardiovascular disease. So when you think about this being the leading cause of death in women by and far, cardiovascular disease, the fact that menopause is like just entering the conversation,
Right.
wild.
Right. So when women are starting to make a plan, a health plan, hopefully with their healthcare provider, hopefully with their,
As they bring in those, if they got their 10 minutes and they got their journal down and they've like, okay, I did everything Dr. Hirsch did.
and they start advocating for themselves a little bit better with a little bit more self-confidence, I hope. And they start thinking about the next phase of life, because it is the next phase of life. And that we've talked about this, that menopause just really, it doesn't really end, it's post. Right? You go into your post years, but that doesn't mean that it's completely over, that you could be having all of these symptoms for decades. So we're starting to think about our health plan for the next 3 or 4 decades now.
Yes.
So we have to have these plans
Yes.
around how we're not just going to feel better today or next month. That
Yes.
is an ongoing journey.
Yes.
And advocacy will continue. We have to continue with our advocacy, particularly when we have doctors telling us you have to come off your HRT or whatever medications after 10 years, that you're not a candidate over 70 or 75 to go back on HRT or whatever it is that you are feeling. And in closing, I want you to talk a little bit around that advocacy, because it makes such a huge difference for women who are struggling with any kind of mental health condition or issue right now, around depression or anxiety for the first time in their life, and around bone health and heart health and vaginal health.
You know, I may be changed my mind on this, but I'm kind of, every year on my birthday, I feel more confident. Like I know, just come for me later, but I love getting older.
I do too.
And I think that when menopause hits, we are truly our very best, and we're going to continue that. But women in this age group, 45 to 55, 50 to 60, those are the years. You have financial freedom, hopefully. You have, done so much in your life. Maybe you've had your kids or whatever. It's a beautiful time. And then to tragically get hit by menopause, it is so unfair. And we are really the fabric of society. We all know that. And society needs us all also to function and feel our best. So when I talk to women about, for example, bone health, I do this all the time. I make this analogy, and I'll look at their bone density and I'll say, bone density is kind of looking a little losing some bone here.
A little osteopenic.
Yeah. And, they'll say, well, I don't really want to do anything now. Okay. And I always say, and this is kind of going to transition to this, I'm not worried about your bones tomorrow. You're not going to probably break it tomorrow. But in 2 decades, when you're out skiing, I don't want you breaking your hip, because then you're not going to go skiing again. And I'm thinking about you 10 years from now, 20 years from now. In fact, even Shirley had said this when we were doing an Instagram Live. She was like, I'm thinking about how I'm investing in my health for the future.
Right.
And I thought that was so beautiful. And I think that if we almost start to think about this even a little bit earlier, like something I want to touch upon in my next book, as you start into perimenopause, thinking about how do I want to feel? How do I want to feel in 5 years? What do I want to do to protect my health in 10 years? I want to be skiing or snowboarding or traveling in 20 years.
I don't want to wake up 3 times a night to pee.
Or it could be that. Maybe you don't necessarily want to go climb Mount Fiji, but you just don't want to wake up to pee in the middle of the night. And so I think this is so important, because this little cute hormonal shift that we've been talking about really impacts us for decades, and then therefore society, and therefore our partners, and therefore our kids. It's so interwoven into all these different fabrics of our life, and I'm not even stretching. My patients talk to me all the time about their stories. And it's really time that this shift, this transition really makes it on the map. And I thank you, because I think we're doing a really good job. And all of the women who continue to raise awareness, and even if it's just, whether it's having me on a show or just talking to your friends at dinner, all of those things are so important, so that we start thinking, how can we best translate what we want for our life now?
That's beautiful. Thank you.
Welcome.
Thank you so much.